बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम एंड वेरी गुड मॉर्निंग. थैंक यू सो वेरी मच जो आप सब ने हमें अर्ली मॉर्निंग यहाँ पे इस सेशन में ज्वाइन किया. आई वेलकम यू ऑल ऑन बिहाफ ऑफ पाकिस्तान एंडोक्राइन सोसाइटी. आई एम डॉक्टर नीबा सैयद. आई एम वाइस प्रेसिडेंट पंजाब पाकिस्तान एंडोक्राइन सोसाइटी. And for this session, before I start this session or I introduce my expert panels or my worthy speaker, I'd like to start with the recitation of Holy Quran. Can I have the recitation, please?
بسم الله الرحمن الرحيم. إن في خلق السماوات والأرض واختلاف الليل والنهار لآيات لأولي الألباب الذين يذكرون الله قياما وقعودا وعلى جنوبهم ويتفكرون في خلق السماوات والأرض ربنا ما خلقت هذا باطلا سبحانك فقنا عذاب النار. ربنا إنك من تدخل النار فقد أخزيته وما للظالمين من أنصار. ربنا إننا سمعنا مناديا ينادي للإيمان أن آمنوا بربكم فآمنا. ربنا فاغفر لنا ذنوبنا وكفر عنا سيئاتنا وتوفنا مع الأبرار. ربنا وآتنا ما وعدتنا على رسلك ولا تخزنا يوم القيامة إنك لا تخلف الميعاد.
Zakal, I'd like to request you all to kindly take your seats and settle down for a very interesting topic of diabetes, neurological disorders, and the pain management, closing the loop with patient compliance and convenience. For this session, I'll request Dr. Umar Yousaf Raja, Dr. Arshad Hussain, and Dr. Sabah to please take their seats on the stage as experts panels. Thank you so much for joining us. Let me take the honor to introduce our worthy speaker, a name well known, Professor Dr. H. Aamir. He's the head of Department of Diabetes, Endocrinology and Metabolic Diseases at Peshawar General Hospital, Pakistan. Former Professor of Diabetes, Endocrinology and Metabolic at KGMC Hayatabad Medical Complex. Former President of Pakistan Endocrine Society and American Association of Clinical Endocrinologists, Pakistan Chapter. Vice President of South Asian Federation of Endocrine Societies since 2015. He's also the recipient of Donald Elsewhere Award. I'm so sorry, I cannot even pronounce it, and I have never been able to pronounce this award. Sir, would you be kind enough to take the stage? Thank you so much.
Bismillahirrahmanirrahim. Thank you, Niba, for kind introduction. It's called Donald Edsweiler Award. I know, so I'll spell it and give it to you. Thank you. First of all, thank you for the colleagues who are here early morning, because usually afternoon में evening के sessions में we say कि यार kursiyon wale hain, या जो है तो जोर से बिठाया हुआ है या कंपनी वाले हैं, but I'm so glad a lot of our colleagues are here first thing in the morning. I can't promise you this presentation is going to be very interesting for various reasons. And one of the reasons is that having worked abroad, and I'm sure many of us who have worked abroad and work in Pakistan, one of the most debilitating complication of diabetes, which we just can't get over, is diabetic neuropathy. I'm sure everybody would agree with that. And because of that, sometimes we often feel that we have failed the treatment for our patient. And I think partly the main reason for that is that diabetic neuropathy probably is not really well understood to date. And that's because there's so many pathways which are involved in causation of diabetic neuropathy. So without further ado, I'll just move forward. These are my disclosures. We know there is diabetes is on a surge, and for Pakistan it is not a brilliant situation simply because we are the leaders of diabetes in the world, and I think the way things are going, no actual plan of how to reduce it, we will continue to be the leader for a long time. We could have been the leader even in terms of absolute number of diabetics, but because the population of China and India is much more than us, that's why we are not leaders in absolute number, but in terms of prevalence, we are the leaders. And when we talk about being a leader, obviously the complication comes with us, with many complications, but here I'll be talking basically about diabetic polyneuropathy. This may be slightly controversial slide, but how many of you agree with this? So I don't need to explain anything. It is a gift of God, because if you are in pain, you will seek attention. But the problem is when it's painless. And the classic example I give to my patients in terms of diabetes is that, unfortunately, if somebody has got a renal colic, they will rush to the doctor to seek help. If somebody's got an appendix which is swollen, tender, inflamed, they will run to a doctor. Diabetes is such a disease where there's no such thing in terms of diabetes as of pain, unless they come up with a complication. And one of the complications is diabetic neuropathy. With this pain in mind, I'll give you two cases and the story of two nails. And this is a builder. This is published actually in British Medical Journal. This is a builder who actually, while working, had a nail into his feet through his boot. And he was crying with so much pain that he has to be taken to A&E, where he was given sedation, strong painkiller. While sedated, his nail was removed. And then, while he was sedated, his shoe was removed. And to surprise, the nail didn't touch his foot at all. It was actually through the web of the toes. This is a second case, again, a builder with a nail gun. In the builders, they use this nail gun. And he accidentally shot himself without realizing the nail has gone. And he was not bothered about it. It was only after 7 days that he had some pain in his jaw, and he thought it's a toothache. So he went to a dentist. They did a scan, they did an X-ray, and this is what was found. So actually, this is a story of two nails, hyper expression and no expression or less expression of a disease. The reason I put this slide to begin with was pain is a complex modality. And by looking at this example, one can realize that why this common complication of diabetes is not fully understood and it's not properly managed for various reasons, but one of them is that because we don't know the pathophysiology completely very well. So I'll be talking about painful diabetic neuropathy, mechanistic descriptors, neuropathy and diabetes, multimodal pain management, and role of pregabalin for this talk. Pain arises from actual or threatened damage to non-neural tissue and is due to activation of nociceptor. There's another example of pain where there's a tissue damage and there are inflammatory markers, they come in. There's neuroinflammation at the nerve ending, but overall, in this type of pain, the neurological function, the nervous system is absolutely fine. Compare it to this type of neuropathy, where there's a herpes, you can see there's a severe pain or tingling and burning feet, phantom pains, so on and so forth. Compared to the last one, there is a nervous system damage in this pain. And then there is another one called nociplastic pain. This is a pain without any identifiable nerve or tissue damage. And the common example of that would be fibromyalgia. We all see very often. Backache, for which no identifiable cause can be found, migraine, and so on and so forth. So there are three types of mechanistic descriptors of pain: nociceptive, neuropathic, nociplastic. If they are so clearly defined, it would be easier, but they're not. And the problem is that you can present with a mix of any of these. And then on top of that, there's another called low back pain, again, the cancer pain, and so on and so forth. So the purpose of presenting this first slide of three types of pain, they could be separate, they could be mixed, and to be a combination of one or the other, is that pain in neuropathy itself is a complex phenomena. You mix it up with diabetes, which has got its own problem. We know that overall, 50% of patients with diabetes will have some sort of neuropathy one way or the other. And we have estimated in our study done at Hyderabad Medical Complex, around 40% of our inpatients are definitely diabetic. And it can be more. So that's why there's a range global prevalence of 30 to 50%. And obviously it depends on many factors which can affect diabetic neuropathy. There's a preponderance more for female and of course for poor glycemic control. It's not an easy disease to manage simply because it affects the patient's life generally. And if you look at mood, walking ability, general activity, all these are affected. What is more important is that sleep is affected. And if you can't sleep well, you don't wake up well. And all these are general elements, but they do impact patients' life. This is the study I was referring to. We've had our study in which around 43% of our patients were affected in diabetes as an inpatient, and one could argue that inpatients are usually a severe class of patients, but this is what we saw. So, types of pain, and then what is the prevalence of diabetes and what's the prevalence of neuropathy in it? Are there any signs and symptoms of this particular condition? Yes, there is. And one of them could be a burning pain. Sensitivity, hypo or hypersensitivity, depending on where it is involved. It could be a muscle weakness, lack of coordination and balance, and of course the skin changes and nail health which can be affected with it. So if you have a patient with diabetes who's got a long duration of diabetes, the likelihood is that they will have some sort of diabetic peripheral neuropathy, what kind it is, that which fibers are involved, whether they're a small fiber or large fiber. For practical purposes, it doesn't matter. But from management point of view, it may matter. So what will be our strategy of how to go about this neuropathic pain for our diabetic patient? So with the metabolic condition at the top, we know that VESA, Vizoram, and all that microvascular complications leads to decreased perfusion and nerve ischemia, and there is altered nerve function, which can lead to diabetic neuropathy. But we also know that because of a metabolic disease, there is an oxidative stress, there is inflammation, and all the pathways related to it, and myocardial dysfunction, all these can affect the nerve function, and then patient can have both painless or painless diabetic neuropathy. I think this is very clear. But even if you know all this, even if you address all this, what will be the management of reduced inflammation, oxidative stress, and myocardial dysfunction? You will give something to improve the metabolic function. But even if you've done that, we have done in our patients that when we control their diabetes too quickly, they get into severe pain, which is not treatable with any of the treatments available. So the point here I'm making is that it's a complex disease. It's not as simple as it looks. And that's why it becomes very difficult to manage sometimes these patients. Then on top of that, there are other factors which are involved. B12 is one of them, which sometimes is probably underestimated, but we need to look more often into that. But then there are other genetic factors and inflammatory markers which do affect. There was a study on vitamin D. I think study was done in Pakistan as well, that it does improve. I'm not a very fond of vitamin D, and I say it very loudly because I think it's all a hoax. I don't agree with that, but that's my personal view. But having said that, this has all been mentioned. One would argue that if we don't know what is the pathology, is there any identifiable structural changes? If you look at these identifiable structural changes, one would again argue that if you have one change or the other, how does it affect the outcome? So here, there are reduced epidermal nerve fibers. Here there's reduced myelinated nerve fiber density. Here is a capillary pathology, and then epineural vessel pathology. And then there's a central mode of pain transmission. So peripherally we have seen all this, and then centrally there are effects in the cerebellum as a sensation of it. Our colleague Dr. Riaz Malik is fond of it, and he has worked a lot of work on the cornea and looking for the neuropathy based on the corneal examination. And then there are pathways which are involved, and obviously this is very complex, but for the purpose of understanding what I would say is that There are different type of fibers, larger, smaller fibers, and depend which fibers and which area are affected, the patient can have symptoms related to that. So we need pragmatic approach that how to approach the screening and diagnose diabetic peripheral neuropathy. I think no matter what kind of disease you are dealing with, I think it's very important that you stick to the basics. And the basics are always a good history and examination. So history taken cannot be overcome by any advanced investigations, though there are investigations available, but a good history, metabolic history is a cornerstone. You need to know how long the person is affected with diabetes, all the other risk factors, including the hyperlipidemia, social determinants, or so on and so forth, need to be looked into. And they assess the diabetic polyneuropathy depending on what kind of pain do they have. If the pain is burning, lancinating, and shooting electric worse at night, there's a different algorithm to it. But if the symptoms are numbness, poor balance, and weakness, then we assume that the large fibers are involved. Once you know the history, you know what kind of problem there is, you can go for clinical testing. And I will not go to modern testing, but the simple monofilament test, the simple vibration test, which we often forget, is something which will give key. And once you find that, that they have bilateral symmetrical, sometimes it could be asymmetrical as well. If they have that, and then you can pretty certainly think that this is diabetic polyneuropathy and not something else. But you always need to look for other causes if it is asymmetrically distributed. This is what we see very often. That's typical gloves and stocking on mononeuritis or plexopathy, and more commonly we see more in a tertiary care settings, autonomic neuropathy. So what to do once you've diagnosed the patient has got some sort of neuropathy? It is a diabetic and it is a metabolic, and you have assessed all the other risk factors associated with it. Again, as I said earlier, I think it is important that you go for the basics, which is a good history and good examination. Nothing can replace a good history and good examination. Once you've done that, I think in terms of management again, a basic behavior intervention, including exercise, dietary modification, is an important element. And once you have addressed that, you can go on and find the management required for these kind of neuropathies. Now, pharmacological points are there. And again, I would say that if you look at your drugs available to us, which is anticonvulsants, SSRIs, tricyclic antidepressant, the three drugs commonly available work in a different way. One can argue that they work in a different way for different pathology, but the other understanding for that would be that because we haven't understood completely neuropathy, that's why we are trying with one or the other or the third drug. So multimodal pain management, I think that is more of a basics, what we need to look into. So the basic exercise, metabolic control, and psychosocial help is what is required for these patients to reduce the pain, maintain the function of that patient, particularly with a diabetic polyneuropathy, and to prevent any future exacerbations. Despite all these common things which we must employ, if the patient does have complicated neuropathy, we go for management. Antiepileptics, among the two common are pregabalin and gabapentin. Antidepressant, as I said, tricyclic and duloxetine and venlafaxine. And then questionable, but there are local preparation of capsicum and lidocaine available, and it is also suggested that if patient do have severe painful neuropathy, you can use tramadol and strong opioids. So if you look at the list of these drugs, the action of all of these drugs is very different, but they're all focusing on one thing, which is diabetic neuropathy. So what we do practically, pragmatically in our situation is that we use these drugs with the comorbids that they may have, the symptoms that may have, which need addressing. These are the recent guidelines of pharmacotherapy of painful diabetic sensory motor polyneuropathy and neuropathic pain in general. And on the top, you see a lot of these champion organizations who have recommended what we need to use commonly in these. So here, tricyclic, duloxetine, gabapentin, and pregabalin are there, and of course the tramadol, capsicum, and all those are included. So these are the pretty recent guidelines, early part of 2022, and they are all published. For the purpose of presentation here, I'll be only looking at pregabalin. Now, we need to consider pregabalin if there's impaired sleep, anxiety, and polypharmacy already with the patients. We can consider that, but one of the problems which patient may experience is when you use these drugs, they feel very sleepy. And as seen with many drugs that are available to us, be that statins, be that antihypertensive, so on and so forth, our population reacts very differently to the population in the West. The dose required for polyneuropathy, once I was talking to Riaz, that patient doesn't respond, and he said, what dose you use? The dose which we use here is pretty small dose. But despite that, the side effect profile of those drugs are very high. And when we talk about the sleep, anxiety, and so on and so forth, there is a problem related to that. We need to adjust the dose for renal failure. The other important factor for treating these kind of pains with a pregabalin is the escalating dose. Now, for that, you need to wait. So starting somebody on X dose doesn't finish your job. And that's not the art. The art is how to titrate that dose to be effective for that particular patient. So generally we say start slow and then gradually build that up for additional dose to go on. As a comorbidity of sleep, if you use pregabalin, it obviously helps. But today, I'm briefly talking about controlled release pregabalin preparation. This is a combination which was not available to us before. So there's two drugs, which is one is immediate release and the other is controlled release. The proposed dosing of pregabalin extended release or slow release is once after the meal, evening meal, because it is released very slowly through the gut. And the two commonest indication for use is diabetic polyneuropathy and post-herpetic neuralgia. Now, the control release allows for more consistent blood levels of the medication, reducing the fluctuations and improving symptoms. And what I've found practically is the reduced dizziness and somnolence and partially reduced peripheral edema, which can happen with a high dose of pregabalin. Because any drug which is given in a OD dose has got a beneficial effect in terms of compliance of the patients. And if you use in the evening, I think the sleep is an additional benefit that you can get. So compliance is one benefit. Reduced consistent plasma concentrations is another, and we know that there's a better safety and enhanced efficacy based on some of the trials which was done, and one of this is safety comparison to immediate release, in which it showed equal effect with a single dose. It has been also used in fibromyalgia, which is another complication, because most of our patients with diabetes do present with myalgias which are not manageable with ordinary treatment. So pregabalin is one of the management tool which we can use, and it does improve the symptoms compared to placebo based on this study. As I'm short of time, I'll skip a few slides. So the peak concentration is 8 to 10 hours, but the duration of action is 24 to 48 hours. One thing which we should be wary about is the renal clearance of these drugs. So depending on what kind of renal function do they have, if their creatinine clearance is more than 60, you can start off with a rather higher dose of 165 and build the dose up to get the beneficial effect for depending on what the patient can tolerate. If the creatinine clearance is between 30 and 60, you can start off with a smaller dose and build it up depending on what they need. And if the patient is on renal replacement therapy, then obviously the dose can be given late after the dialysis is done. These are the equivalents for some of us who are using the older versions, which is 75, 150, 300, and so on and so forth. So these are equivalent of the effect which you can gain by using these drugs for our patients with diabetic neuropathy. Again, the same slide for creatinine clearance and what you need to do for these patients in terms of renal clearance of these patients. So there is an advantage of single dose therapy on a controlled release drug for neuropathy. We have seen this in particularly controlled release or slow release in metformin. And some of our patients who don't tolerate the plain metformin very well, we have seen the benefit in those patients with the controlled release. Same applies to controlled release, but I personally refer it to the side effect profile, which could be minimized for these patients who are using controlled release pregabalin for control of their or management of their symptoms. So it's a once daily dosage, it's cost effective, and it's better safety and efficacy profile. So in conclusion, ladies and gentlemen, pain is a complex phenomena. It is a gift of God, but it is a very complex phenomena. Diagnosis is important to guide the therapy, depending on what kind of fibers are involved. But pragmatically, it doesn't matter, because we have seen that sometimes patient doesn't respond to one treatment and you may have to switch to another treatment, and sometimes to a small dose of two treatments which we can use. And that's what we call personalized medicine. Multimodal management, the basics remain there. And all the other polypharmacy may be required. So two drugs may be mixed up to see the effect. Pregabalin, we know, generally has been with us for a long duration of time, but one of the problem related to pregabalin was the dose and the side effect and the frequency, which can hinder the effect. So with the new CR preparation, I think we've got a benefit of using this CR preparation for better convenience and adherence for our patient. I thank you very much for your attention. I think I just finished in time.
Thank you very much. Yes, for such a wonderful talk early in the morning. And I think we finish on time as well. So I have few questions from the audience, but I think we can only take 2 questions.
Okay.
And then we'll conclude the session and we go to the next one. So the first question came here is, what is your expert opinion regarding mirogabalin compared to pregabalin?
You've asked for my personal opinion. My personal opinion is that I'm a fond of one drug, and I develop experience on one drug. So, so pregabalin I've been using pretty often. My personal experience is very good. The only side effect, as I said, mentioned earlier, is the side effect profile of this drug, which can be really troublesome when you titrate the dose, because titration is important. So when we titrate the dose to a higher dose, that becomes a challenge, and then the to be or not to be, what to do and what not to do, it becomes very difficult. So my personal experience, my personal preference is pregabalin, one, and it's a smaller dose, a controlled dose with a combination of other group of drug if the symptoms doesn't settle.
Okay, and one more question is, what's the role of supplements in diabetic neuropathy?
It's a complex, it's a very complex, I think, field. So yesterday somebody asked about vitamin E in MASLD and all that. And there are very weak studies related to vitamin E, but we still see that people are using it. So I think a high dose of cobalamin may work, supplements may work, but I cannot be saying this, standing on this podium and saying that, no, all the supplements work. So I think it has to be establishment, and maybe when all fails, you just try the supplements.
Okay, I think that's it for the questions. Now we move on to the panel for conclusion of the session.
Okay, so just to conclude the session, thank you very much, Yousaf, for such a wonderful presentation. I think the main thing is that diabetes peripheral neuropathy is very complicated to treat. We still have limited treatment options for diabetic peripheral neuropathy, and I think early on, for me as a personal experience, the way that our population work or response to medication is quite different to, say, abroad, or I mean, you and I have both worked in UK, where duroxetine was, I think, projected as a medication with very few side effects. And the first thing I learned was not to give 60 milligram duroxetine in Pakistani population, where you're getting calls here and there about the nausea, vomiting, and sleepiness. And very soon, my first go-to drug here in Pakistan for diabetic peripheral neuropathy is pregabalin. But then again, there are people who are coming with the side effects like dizziness and somnolence for some of them as well. And I think I agree with you completely that this control risk pregabalin is a good addition to our armamentarium for treating the diabetic peripheral neuropathy, and maybe combining it with then small dose duroxetine or small dose triptylene will help in the pain relief for these patients. I think the other thing, I mean, I'm quite happy that you have been doing these prevalence studies on diabetic peripheral neuropathies, because this is where we are lacking. I think we need more data from more centers about what's the true prevalence of diabetic peripheral neuropathy. Even Riyaz Murad didn't have, he was here about few weeks ago, and he didn't have the data about what's the prevalence of diabetic peripheral neuropathy in Pakistan, which means there's such a dearth of data from our part. So overall, I mean, with this, I would like to conclude this session, and thank you very much again for your presentation. And I'm going to start the next session by inviting Dr. Siddha Rodi, who is going to start chair the next session.